Well, welcome and thanks so much for joining me today for episode 10 of season 4 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hochman. I want to again begin by thanking and acknowledging the SCAN Group and SCAN Health Plan for funding and sponsoring the Healthy Skeptic MD. SCAN is one of the best known and best respected nonprofit Medicare Advantage plans in the nation. It is got a strong reputation of working with frail older populations, and I'm very proud to work in affiliation and association with the SCAN Group. My comments on this podcast are my own and do not represent those of SCAN's, however. So today I'm very fortunate to be joined by a physician, Dr. Chandana Banerjee, who recently wrote a very important piece in the Orange County Register that got national attention about the End-of-Life Options Act here in California. The law authorizes the compassionate option of medical aid in dying for terminally ill patients. It enables a peaceful death for those suffering at the end of life. Dr. Banerjee is a palliative care specialist at the City of Hope Cancer Hospital here in Southern California. In addition to her medical career, she somehow finds time for poetry and has published a couple books on poetry, as she'll tell us about today. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever you listen to podcasts. Search for us on YouTube and subscribe to the YouTube channel. Pass it along to friends, family, and others who might be interested. And I would really appreciate it if anybody finds today's episode engaging and would like to leave a review. Okay, so before we jump into our interview with Dr. Banerjee, let's kick it off with a rundown of the health news of the week. And the first item I want to talk about is a new study by a former guest on the Healthy Skeptic, Dr. Peter Cohen. As you may recall from that episode, Peter is a nationally known expert on safety risks of over-the-counter dietary supplements. And last week, he published an important new study on the risks of a dietary supplement called Phenibut, which manufacturers have suggested provides mental health and calming benefits. The compound, unfortunately, has also been linked to some serious safety risks, including coma and death. And in fact, in 2019, the FDA issued an advisory clarifying that this compound is not safe and should not be made available in over-the-counter supplement products. But in Peter's new analysis this week, he found that manufacturers have not been heeding this FDA advice. And in fact, he found the compound present in several commonly sold over-the-counter supplements. And in some cases, the doses of Phenibut in these compounds was 4.5 times what the standard dose is in other countries where the compound is legal and allowed to be used. Now, sadly, this is far from an unusual finding, as Peter described in that previous episode in which I had him as a guest. Manufacturers commonly ignore FDA guidance and even requirements, and the FDA has very little regulatory authority or capabilities to prevent this from happening and enforce their guidance. So if you do want to learn more about these important safety risks with supplements, go back and check out that previous episode from a few months ago on the Healthy Skeptic MD with Dr. Peter Cohen. The second study I want to highlight this week is a new analysis in JAMA Internal Medicine about racial and ethnic disparities in health and access to care after the age of 65. So there's both good and bad news here. So the good news is that after 65, when most Americans become eligible for Medicare, many of these disparities do improve. So for example, there's a greater than 50% reduction in the black versus white disparities in health insurance status after 65, and the gap in influenza vaccination rates between whites and Hispanics decreases from 8% gap to down to a 3% gap. And presumably that's due to the fact that everyone is eligible for Medicare after 65. But the bad news, of course, is that these gaps are not eliminated entirely. So it suggests that providing universal health care, health insurance in the form of Medicare is an important factor that can reduce health disparities, but it doesn't tell the whole story. And I think this is a very important insight for policymakers to consider. So I wanted to highlight it today. So that's it for the health news for the week. Let's jump into our interview with Dr. Banerjee. Thanks so much for joining me. Welcome to the Healthy Skeptic MD, Dr. Chandana Banerjee.
Thank you for having me, Dr. Hochman.
Well, You have a very interesting career. You are a palliative care specialist at one of the nation's leading cancer institutions in the country that's known for high-tech care, really miraculous cures. How did you how did you end up in this field?
I think it's interesting in terms of my journey to City of Hope, but definitely at City of Hope, I wear two hats. So until last February, I was an assistant clinical professor in supportive medicine, doing that role 100% of the time, where I took care of complex patients and supported all the primary teams, whether it's the oncology or the hematology teams, in providing support to their patients that were going through disease trials or treatment options. As of February 2020, I also took on the role of the director and the designated institution official for graduate medical education. And in that role, I oversee various residency and fellowship programs we have. I still maintain my clinical practice, primarily in the outpatient setting and occasionally on the inpatient side. And within this field, I get to do a lot of fun stuff, including working with wonderful faculty and research staff.
Could you just tell us a little bit about City of Hope, the institution?
Yeah, so City of Hope, it's a NCI designated cancer center. It's one of the NCCN cancer centers. It actually was set up initially early on, about 100 years ago, as a tuberculosis sanatorium. That was the history. There were 2 tents in Duarte, which is 20 minutes out of Los Angeles, and that's how it started, as a place to treat patients that didn't have a cure from tuberculosis. Consequently, obviously, it developed as a cancer center, and it also developed as a diabetes center. In the insulin, the patented insulin came out of City of Hope. We have an amazing cancer and diabetes research center here with numerous trials, numerous advances, and numerous medications and therapies that are created here. This center also is one of the leading centers for bone marrow transplant, which started here numerous years ago.
Yeah, certainly in the Los Angeles area, it is known as the place to go, for really if you need a very specialized cancer treatment. So why is it important that an institution like City of Hope that is focused on, beating cancer in very high risk situations, why is it important that they have a palliative care team?
So I think it's important to understand that, research and studies have shown that the presence of palliative care programs at institutions, especially those that treat serious illness or terminal illnesses, highly improve the patient's quality of life. As we'll probably talk about this, studies have shown that palliative care involvement early in a patient's disease journey, actually improves sometimes their living, their quality of life. They can live longer. Palliative care, I feel, is a field that encompasses many domains, still very poorly understood in the medical field. It involves the practice of treating not only the patient for a variety of the symptoms they experience from treatments, let's say in this case chemotherapy side effects, or even the disease progressing. But palliative care also takes a very spiritual and psychosocial approach to addressing the patient's needs and concerns as they go through their journey. We know each patient's journey is unique, and oftentimes palliative care is the subspecialty that other specialties come to when we need to discuss things like advanced care planning, goals of care, delivering serious news, or even prognoses, which is telling them how much longer they have to live or how long their lifespan is going to be.
There's a lot of anxiety when the term palliative care is mentioned. There's certain connotations that it brings up. How would you describe palliative care? And, is it, does it mean giving up, for example?
So I think another important thing to understand with palliative care is really what palliative care isn't, right? So palliative care is not end-of-life care. Misunderstandings around it often contribute to both clinicians and patients not really approaching it or availing it in time. In the end, it's the patient that loses out on the services that palliative care can offer. So, to simply put, if you look at the National Hospice and Palliative Care Organization's websites or their literature, you'll see that it says palliative care does not replace the patient's primary treatment. It works together with the primary treatments being received by a patient. And the main focus is on pain and other complex symptoms and the stress of serious illness while being offered curative treatments. So palliative services can be sought at the beginning of a diagnosis all the way until a patient's death. Also, many patients are terminal, but often still hesitant or afraid to select hospice services. They can still benefit from palliative care when this happens. In contrast, palliative care stands with hospice care. Hospice care is an umbrella under palliative care. Hospice care is a continuation of palliative care when the prognosis is 6 months or less. The goal of hospice care is to provide comfort through pain and symptom management, psychosocial and spiritual support. And usually patients elect hospice when there are either no curative treatments available or left for them, or they on their own choose to forego curative treatments due to the burdens of therapy and often loss of autonomy in their own lives.
So is it fair to say that palliative care is focused on managing symptoms, whereas hospice is more end-of-life care?
Absolutely. So hospice care is usually in the last 6 months, give or take, of a person's lifespan. Hospice services are offered to almost everyone in the United States, and they're funded by the government. And usually these services are provided at home, in the patient's comfort zone. Sometimes they can be provided in centers and facilities. Many times people ask me, Dr. Banerjee, if I sign into hospice, will I be able to go to the hospital? Absolutely. You're not signing anything away. It does not mean that you're giving up treatments. It just means that you're changing the focus of your treatments from curative to comfort.
Well, I think it's one of the most misunderstood fields in medicine. And I think the unfortunate result of that is people don't take advantage of the services. There's this mindset that if you're taking a palliative route, that's giving up. And what I often tell my patients is, actually, it's an extra service to focus on symptom management and comfort and quality of life issues that, maybe even in parallel with life prolonging treatment. And when you enter the hospice phase, the focus really shifts more to the comfort part of it. But in my book, it's a majorly underutilized and misunderstood field.
Absolutely. And I totally agree with that. I think palliative care as a field is very young. And if you just look at the history of how palliative care has evolved, right? Really, it has been used for centuries. If you look at some of the historical literature and examples that we even see in the churches when they provided treatments to those that were suffering and at the end of life. But just to take a look at the modern day palliative care movement, right? It was around 1967 that this really came out of England, where you had Dame Cicely Saunders, who was an amazing woman with degrees in nursing and social work, even medicine, that really got this idea of, or introduced this idea of total pain, which not only included the physical, emotional aspects, but also social and spiritual dimensions of distress. She was the first person to found a hospice which opened in London and was named St. Christopher's. Now, this was in 1967. Mind you, in 1969, Elizabeth Kubler-Ross published her book on death and dying, which brought death and dying to the forefront. And in 1974, the dean of the Yale School of Nursing was so inspired by Dame Cicely Saunders when she came to present at Yale that Florence Wald followed her back to England, looked at her hospice, and then came back to establish a hospice, the first hospice in the United States, which was in Brantford, Connecticut. Around the same time as this was taking some momentum, it was in McGill University in Canada that a surgical oncologist coined this term palliative care, basically to distinguish it from hospice care, so people actually understood the differences. It wasn't until 1980 that actually the federal government mandated that hospice care be covered by Medicare, so quite a long time after its introduction. And it took till 1990 for the World Health Organization to actually recognize it as its own specialty. So I think as a country, we've come a very long way in embracing palliative care and the approach that palliative care has, especially as other clinicians see its value and its support to them. However, it is something still not available to all patients, and certainly not all clinicians understand it in its entirety.
It's interesting. At one level, palliative care is one of the most basic things we can do as doctors is relieve suffering. How did you become interested in palliative care?
So my journey into medicine is a really interesting one. I bet many people, I think as kids, know that they want to be doctors. I think I've just known so many people that just knew that they wanted to either be a lawyer or a doctor. I never really intended to be in clinical medicine. And that was definitely something not on my radar. My primary passion was humanities and literature. But then my father suddenly passed away when he was visiting India, getting septic to secondary to a surgery that he had. And I think that moment was my calling to enter clinical medicine. And I went to medical school. And then as I meandered through medical school, I found that medicine in general was highly focused on fixing the problem. Physicians often felt stress and anxiety when disease and problems were not fixable. There was many a times when I felt when it came to care around serious illness, especially when cure was not an option, prognosis was discussed with patients and families a little too late. I think those experiences, including, my own experience of my father's situation, led me to medicine and ultimately palliative care.
So you're a national policy expert on many of these issues, and we're going to dig into them shortly. But before we do, one more warm-up question. You mentioned at the beginning that you are the training program director. It seems to me a very interesting place to train, a national cancer center like City of Hope. What types of training programs do you offer?
Yeah, so City of Hope is absolutely a fantastic place not only to work at but also to see trainees come out of. So we are a cancer center, and so most of our programs are focused on subspecialty care in and around cancer. Many people do not know this, but City of Hope is also one of the only NCI designated standing centers that has a hematology and oncology fellowship program. We are not based off of an internal medicine residency program. We have our own program. We launched it a few years ago, making it one of the few in the nation. Actually, it went into effect last year. And the same goes for our hospice and palliative program that works with oncology and hematology programs. It is the only one on the West Coast that is in an independent standing cancer center. Our programs here are focused in cancer, but other nuanced care around cancer. And we have multiple programs in surgery, pathology, transplant, gynecologic oncology, urology, to name a few. We also have a radiation oncology residency, and it makes City of Hope makes it an exceptional place to train just because of the majority and the talent we have.
Well, congratulations. Really impressive role that you have at the institution. And let's dig into some of these policy issues. So the first is that I think there's often a misunderstanding about what palliative care can do for patients. And I'm the author of a book called 50 Studies Every Doctor Should Know. And one of my absolute favorite studies in that book is one about the role of early palliative care for patients with advanced lung cancer. Could you tell us a little bit about that study?
Yeah, absolutely. So I think you're referring to the 2010 study by Dr. Jennifer Temmel, I believe, right?
That's the one. Yes.
That addressed the early palliative care for patients with metastatic non-small cell lung cancer. So that study in itself was monumental for a couple of reasons. Keep in mind, as we said before, that wasn't really until just a few years before that palliative care was even recognized as a medical specialty with its own board certification. So that in itself, just 4 years after that, to have this study published, which made huge impacts, was monumental. So this particular study showed that people with lung cancer who received early palliative care, in addition to the standard oncologic care that others receive, experienced really less depression and increased quality of life. It also showed that they survived about 2 and 2.7 months longer than those receiving just standard oncologic care. I believe that study became monumental for the movement of bringing palliative care to mainstream medicine and the positive effects it had when appropriately used. I think it gave validity to the field, and we saw palliative care really boom and really absorbed by mainstream medicine in the variety of serious illnesses that could use palliative care. Ultimately, I think it is one of the earliest studies that propelled research and education in this field.
Yeah, it certainly changed my mindset. I always was a big believer in palliative care because it improves symptoms and quality of life, but it's not what many of us would have expected, that it would have actually lengthened life. And actually, there was a lot of politics at that time. There was a certain unnamed politician that I won't name who referred to palliative care as death panels, and this seemed to really counter that. That it actually was a life panel in addition to improving symptom management. So so that was a big moment in the field. Another topic that you've been a real leader in is the End of Life Option Act, and you wrote an op-ed piece that got national attention a couple months ago. Could you tell us a little bit about the California Life Option Act?
Yes, absolutely. So this is a topic that's really near and dear to my heart. So medical aid in dying in California is known as the End of Life Option Act. And it's sometimes incorrectly referred to as assisted physician suicide or euthanasia. Let me just be very clear and correct those that don't understand it. It is not assisted suicide, it's not suicide, or it's not euthanasia. And these terms often make it misleading and factually are incorrect. So let me explain what medical aid in dying actually is, and I think maybe that'll allow me to explain the policy a little bit better. So medical aid in dying, or EOLOA, is a medical practice that allows terminally ill, competent adults who meet certain eligibility criteria to really get a prescription of medications to ingest them peacefully and end their lives on their own, right? It allows eligible options to use this as one of the many other options that are also available at the end of life, which many patients turn to when either they have heavy symptom burden or they have loss of autonomy due to their disease progression. And we know that their diseases aren't reversible. We know that death is inevitable. We know that they're losing autonomy with each passing second in their lives. And all of them have 6 months or less to live. We know that. That's the eligibility criteria. The End of Life Option Act allows patients to self-ingest the very similar medications used in palliative sedation or comfort care, mainly a cocktail that puts them in a coma within 30 minutes, and most patients pass away peacefully within a few hours or even minutes. It allows them to do it when they are ready, on their own terms and in their own time, and then in their own home setting. So this End of Life Option Act is legal in many states, and we are, as physicians, working towards making it available to all Americans.
How many states is it currently legal in?
Quite a few, and actually there's a couple of states that is going, it's about 10 plus Washington, D.C., and there are a couple of states that are currently on the cusp. So this particular option took effect in California June 9th, 2016. That was the first time it got passed here. And it has been implemented in multiple institutions around the state. However, there were a few flaws that this particular bill had. So the current bill that has been proposed is the SB 380. Basically will improve upon the law and make it more so that eligible Californians are able to access the law easily, right? Key improvements in that law include shortening the waiting period to 48 hours. So currently, as we look at it, a patient comes, if they're eligible, they come to a physician, they ask for a verbal to participate in this act, and then you have a 15-day waiting period in between which you have a consultant also verify that this patient is eligible to participate, and then after 15 days of when you first see your primary person who's going to be your prescribing physician, then you get to do the second verbal and get the script. Now, many patients that are in the state are losing autonomy, and they're progressing rapidly. Not only that, the symptoms and the burdens of the symptoms on them are really terrible when you actually see some of them. Many times they progress really rapidly that there's not enough time between the first time that they ask their physicians to the 15 days waiting period. So it really does a huge disservice. It's not that people get up suddenly one day and say, oh, I'm going to opt into using the End of Life Option Act. They've been thinking about this for a while. They know their diseases are progressing at a rapid rate. So this 15-day period really doesn't make any sense. We have places like Oregon and New Mexico that have done away with it. You only need to wait a couple of days before you actually can get your script from the first time you ask. This bill also improves transparency of healthcare facility policies by requiring them to post their medical aid in dying policies on their websites. It really removes redundant fourth requests of the medical aid in dying, the final attestation, the multiple forms that need to be signed. And physicians, even with that, still have so many trepidations on EOLOA as it is shortly called, and often let their personal and religious beliefs influence their ability to be transparent in informing patients really what this option can provide to them. I'm hoping that this bill will educate people, and this bill will be recognized as a huge improvement and change things and pass it.
I actually was not aware of that 15-day waiting period. Making a decision to get one of these medications is certainly a big decision to make, and I can understand a rationale for waiting a day or two, but 15 days, illnesses can progress very quickly in that period, and we're going to lose the benefit if we have such a long waiting period. So that absolutely seems to make sense to me. I am myself a big advocate of this option. I've seen suffering at the end of life, and I would want that available as an option for myself and my own family members. But not everyone agrees with that perspective. And, I've heard the counterpoint that we have a Hippocratic oath and, doctors shouldn't be hastening death. What would you say to someone who did not support the End of Life Option Act for that reason?
I often find that, when people are not supportive of this option, right? There are a couple of things that come into play. One is possibly certain experiences they may have had that may have clouded that picture around death and dying. The other thing is their own personal and religious beliefs and biases that go against this particular option. But also the fact that I think they are maybe, and most of the times, misinformed of what End of Life Option Act is. I think physicians need to really get a good grasp around what this option is and what this option is not. You'll often have these terms like suicide and euthanasia really put out there when certain people talk about this act. But it really isn't, actually. It's really a medical practice, right? It's a medical practice that needs to be, I feel, normalized, just like some of the other end-of-life options that we provide our patients with. It's palliative sedation, which is using very similar medications and really making sure that they're comfortable, but it happens in the hospital. You don't usually put someone on palliative sedation at home. I think ultimately, I feel it is also about a physician and their empathy with the patient and their willingness to give up that control. I think physicians need to understand that patients that are participating or requesting to participate in this act have already been through so much. They've really lost everything there is. And it's not that the diseases are reversible. It's not that the diseases are getting better. So I think it ultimately becomes, how empathetic do you want to be? And wouldn't it be nice to allow them to really pass away in the comforts of their own home?
Hearing you speak, it struck me that, there's so much misunderstanding in the field of palliative care in general. And this is just another example of it. Words have come to have certain connotations, like you mentioned, physician-assisted suicide. Well, that's not really what you're describing. This is empowering patients to manage their own symptoms themselves. Someone smarter than me at branding could, maybe has some work to do about how to rebrand some of these things and use the right language, because I do think that the words sometimes get in the way of good decisions.
I totally agree with you. I think it's one of those that we're trying to get, certain organizations to really reverse the terminology that they use. Also there are many organizations, and for reasons that they may have, that really take either a neutral position or a negative position to the End of Life Option Act, or medical aid in dying as it's known in the country in general. I think people really need to look at it from a humanistic perspective. It is not something that worsens someone's life. It actually gives them a peaceful death, when death is inevitable, and death is really something that patients know that they're going to suffer during the whole process getting to it.
Yep, I think that's exactly the way to frame that discussion. So I want to ask you about one last policy issue. There's been a sort of a recognition in recent years that there may be a shortage of palliative care doctors out there. My first question is, A, is that true? And B, what's the solution? Is it that we should be training all doctors to have these palliative care skills in their tool set?
Yes, I think that's a really important question, and honestly, given the fact that it is still such a young specialty, absolutely there's a shortage of palliative specialists in this country and in the world, actually. Especially when you look at the rural areas where, in general, access to medicine is already an issue. The access to palliative care is even worse, right? The fact is that this is one specialty, like you mentioned earlier on when you spoke, is something that is such a basic specialty with basic principles of humanity and medicine that I think it needs to be taught to almost every physician. And I feel this training needs to start from medical schools. Medical schools put out students that often end up in residencies that have never really had the ability to have a conversation around death and dying. Many times you'll see physicians that have practiced for years suffer with how to have these communications with patients and families. I think it's important that as we see, as COVID-19 and the pandemic has shown us, that death and dying is as important an aspect in our lives as being born or living is. And I think we as physicians need to be prepared to have those conversations. We need to teach our students and our physician trainees how to have these conversations, and more so, how to have these conversations with common sense and with empathy, so that they apply the best of the medical principles when cure is an option, but they also show the humanity of medicine and are able to walk with the patient when the journey does not afford for a curative option.
Yeah, and I have to say, I've learned a lot of those skills in practice. I think I might have had a lecture or two in medical school, but a lot of those things just have to be picked up, and that shouldn't be the case. You don't learn how to treat high blood pressure, your first couple of years in practice. So, I really do think we need to move some of that training further upstream. And it sounds like you're doing that with some of your programming at City of Hope. So I have two final questions for you. The first is, if you could give some advice to listeners. Many of our listeners are lay individuals, and virtually all of us at some point are going to have a chronic illness or prolonged suffering, or a family member who's going to be in that situation. What advice would you give? What should all of us know about the field of palliative care?
So I think people should know that palliative care is a field that involves really coordinated holistic care from the time of getting a serious diagnosis to the very end. And whether that end is curing that disease or whether it is terminally accepting that death is inevitable. But during this entire process, palliative care is a field of medicine that you can deploy. When you look at certain really situations where you have someone in the ICU and things go wrong or things are not curable, there's often panic in family members, there's often panic in patients, and making these difficult decisions around life and death are really more stressful in those times. What palliative care does when involved early is really make sure that you have a very comprehensive approach to looking at not only the disease and where it's going and how it's affecting you and your family, but making sure that you are the center of this and everything is done in a timely manner so that those panic moments do not occur, that you're clear in what you want, you're clear in how you want your treatments to happen or not happen when a certain situation arises. I think the important thing of palliative care is it's that bridge. It's that bridge that holds all of medicine together. And I think that's what makes it special in my heart.
Well, I think that's great advice. The only thing I would add to that is that not every health system is going to offer those services to patients. And so, unfortunately, patients do need to be their own advocates sometimes. So don't be afraid to ask those questions.
Especially those that are in centers that are in rural centers that don't have access. I think you can often find physicians that are trained in the community that or may connect you with someone at other places. So I think it's really important to bring them into your treatment plan.
So my final question for you is a fun one. You are, in addition to being a palliative care doctor and a program director for medical training programs, you are a poet. And you wrote a poetry book called Ashen Leaves, which I need to get and check it out. And you have a second book that's about to be released, Neruda in Bed. Tell us about your poetry.
So that is indeed a fun one. So I started writing poetry very early. I wrote poetry when I was about 8 years old, and I've been writing ever since. My poetry draws on a lot of my observations and experiences and emotions around those observations, and puts those into writing. It's for me an outlet. It's my stress relief. I think everyone should have an activity that they go to, and this is the activity I go to. I really wrote poetry for a long time, and then when my father passed away, I did not write. So it was almost a decade after my father passed away where I started writing again, and this was the journal entry for my Hospice and Palliative Fellowship program. On my last journal entry, I wrote the poem called Grieving to Grieve, which consequently got published in the Journal for Pain and Symptom Management, and I wrote a paper around it. And I think that just gave me the nudge to then keep writing, and I haven't stopped since. So Ashen Leaves has really been a collection of poetry from years in the past and some in the recent present. It's something that is near and dear to my heart because a lot of it is also drawing on my own personal experiences. And then Neruda in Bed is a very interesting one. It talks a lot about love and loss and losing, very much like Ashen Leaves, but it's a different take on love and loss. So hopefully you'll like it. Check it out, enjoy it, and we'll talk more about that. Just don't judge me is what I always say.
Maybe we'll do
Oh, I'm sure it's going to be excellent. And we may do a follow-up episode on it. And so Ashen Leaves, Neruda in Bed, and can listeners get those on Amazon?
Ashen Leaves is available on Amazon. It was published last year. Neruda in Bed should hopefully be released by November. Ashen Leaves is about 146 poems. Neruda in Bed is a little shorter. It's about 70.
Well, I look forward to diving into those, and amazing that you're able to weave some poetry into everything else that you do. So Dr. Chandana Banerjee, thank you so much for joining me on the Healthy Skeptic MD today. If you did find today's episode engaging, please do search and subscribe to the Healthy Skeptic wherever you listen to podcasts. Pass it along to friends, family, and others who might be interested. Leave a review if you have a chance, and please join us again in a couple weeks. Thanks for joining me.